because ADHD is a very fluid episode of care, the work group wanted to make sure that they understood how the PAP or the co-PAP might be assigned. So this page that you see shows a multiple array of ways that a PAP could be assigned. So on the left-hand side, you'll see the point of entry of the person who is doing the initial assessment and determines the ADHD diagnosis. Then you will see in the middle column is referral or consultation, if there were any, and then the next column delineates the PAP. So, for instance, in the first example, the PCP is the provider who had the majority of care because they were the only provider for the episode. So they became the PAP. If you skip down to number 3, you'll see a PCP was the original point of entry and did the initial assessment. They referred to a licensed clinical psychologist who provided the majority of the care for the patient, and they became co-PAPs because the licensed clinical psychologist is dependent on the PCP to write the prescriptions for the medication. Another good example is number 8, where the PCP started the care with the initial assessment, determined ADHD. This may be a good example for which perhaps the PCP saw that medication wasn't going to be all that it took for the patient, so they referred to a psychiatrist or a psychologist within an RSPMI for additional services. So this might be a good example of how a level 2 could be established. The RSPMI provided the majority of the care and became the PAP. So I'll let you just kind of look through those. Most of you probably already have. And so we'll go on from there. We thought it was critical in looking back at the building of the ADHD to provide you some examples of the questions that were asked and the responses that were given back 6 months ago. So that's what this slide represents. People wanted to know how often providers would be provided information on their patients. The biggest way that principal accountable providers and providers will find out information about the episodes is through the reporting mechanism. We'll be discussing reporting next week in our webinar. Those reports will be provided every quarter, and will list the patients for whom that provider is principal accountable in an ongoing episode, and that information, I believe, is going to be in your detail at this point. It also includes current cumulative costs for the episode. You'll also receive a list of episodes which completed during the reporting period, and that includes the detailed costs in comparison of the average cost or episode to the cost threshold. Reconciliation payments will initially occur every 12 months, so we're still a good ways out for the first reconciliation payments to be figured at this point. Another question was, how will current patients be included? When we kicked off the episode, that it was determined that the best way to include current patients is to follow the same logic as the new patients, with episodes initiated for the current patients on the first day of treatment after October the 1st rolled around. Current patients were to begin at level 1 care, but the time restriction on the severity certification was waived, so providers were allowed to certify severity immediately. So if you have ADHD clients that you're serving, that were being served prior to October 1st, and they should be in level 2, if you haven't already went out there and certified them, you certainly want to take a look back and make sure that you get that done. And then the other question was, what is the time window required between level 1 and level 2 severity? For all new patients within the system, providers should at least try for level 1 severity for 2 months before making the determination about whether or not they should really have been put into put into a severity of level 2. For current patients, again, that time window was waived for rollout. And that brings us to the historical data for the ADHD episode based on our version 1 design. I'll tell you a little bit about the preliminary, some preliminary notes on the data, and then Dr. Miller will go into that historical data with you. The data presented in this document is based on Arkansas Medicaid claims and represents episodes that would have ended in state fiscal year 2009 through state fiscal year 2010. So there's 2 years of data that were looked at. The episodes within this data were defined as described earlier in the document. The data presented in this document are not shown with any provider exclusions or cost adjustments unless specifically indicated. Provider data is based on the billing ID. Therefore, it presents all providers in one group as a single provider. And the data here is preliminary and intended to facilitate discussion. Dr. Miller?
Okay, we're going to now look at some of the slides that got us to the historical data. And again, the episode will include patients ages 6 to 17, which accounts for about 90% of our patients and our spend. And we'll talk a little bit about it. So on the left hand of the page, we're looking at the thousands of episodes. Some of the only one ADHD claim, some are comorbid episodes. The third one, the darkened one, are ADH-only episodes with greater than one claim. And that's really the number we're looking at because, again, this episode is only ADHD claimed. It's not comorbid, doesn't include any other behavioral health conditions. So if you look at that 26.1% and go over to the right-hand side, you'll see that the eligible episodes by the age group were about 26,000 episodes, and it accounted for about the total $97 million. And you can see the breakdown that there's about 1% preschool. It's a little bit hard to tell the difference, but 55% and 40%, or really 95% were between school-age children and adolescents, and there was about 4% of adults in terms of the spend, and the other column shows that who was eligible. But again, that shows that the majority of our claims were for school-age and adolescent children. Now, if you look at the next page, the next slide, this is a breakdown, a spend breakdown by service type for patients with no comorbid conditions. And the column on the far left is a total, which is $92 million. And if you may wonder, well, the last slide said 97 million. Why does this one say 92 million? And that's because this includes only the patients who are age 6 to 17. The other 5 million encompasses preschool and adult, which would be another 5%. So this is just those who are age 6 to 17. And if you look further over, the office visits were $11 million, which accounted for about 12% of cost. And the number of episodes, 94%, had this occurrence. The next group showed medication, which was $29 million. And that was the total cost of the percent of total cost was 33%, and 88% of the episodes had a medication. Next column is non-medication interventions, and this was $48 billion. And this includes psychotherapy, counseling, community support, therapeutic activities. And this was 54% of the total cost, and 58% of episodes had this occurrence. Moving further along to the right, there was about $1 million in testing and $0.3 million in other services, which include speech and language therapy, things like that. So it shows you that out of the 92 million, about 54, almost a little over half the cost was non-medication interventions. Now if we move to the next slide, this shows the breakdown by principal accountable provider type for those patients again. And again, it's the same 92 million. And the second column is 14 million. And those were physicians, either primary care doctors or psychiatrists in private practice, and they had accounted for 9,649 episodes, which was about 40% of total eligible episodes. And the average cost for those were about $1,407. And what we're building up to, again, will be the thresholding, which we're going to have a separate webinar on that to drill down on that. The next column, the larger bulk, is $76 million. And this was accounted for by our RSPMI provider organizations, which accounted for 13,018 episodes. 54% of the total eligible episodes were here, and the average cost was $5,838. The last two columns show the private practice psychologists and others, which could include federally qualified health centers or non-RSPMI school-based providers or others. So you can see where the bulk of the cost is in these. Okay. If we move to the next slide, this is the spend breakdown for episodes with physician as the principal accountable provider. And again, the cost breakdown for eligible ADHD episodes was a physician as a PAP. The total cost in millions for Medicaid only. Again, it was $14 million there. These are for physicians. We'll get into the next slide. We'll talk about breakdown between physicians and RSPMI. But these are physician as a principal accountable provider. Office visits were $2 million. Medication was 11, and then you can see the non-medication interventions, the testing, and the others. And again, the majority of the spend here was on the medication. 97% of occurrence had medication, and this was 85% of the cost. So we're beginning to look at differentiating and looking at different models here. This slide, just yours.
This slide breaks out it takes the information that you saw on the previous slide with the $2 million and the $11 million for the $14 million total, and it breaks it out according to where physicians actually fell. So it's the episode cost distribution for all of the eligible episodes. And this is, again, for patients aged 6 to 17 without comorbid conditions. So as you can see, the majority of the providers fell within the range of between $1,000 and about $2,400, with them coming up to the episode count. So, and then as you go on over, you can see where the outliers were, with a little bitty blip there at $9,000. So, but the majority of the costs did fall right there, around $1,500. So next, we are going to look at the spend breakdown for episodes with for behavioral health provider organizations as the principal accountable provider. The total here was $76 million, with $10 million going to office visits, $16 million going to medication, and $47 million going to those non-medication interventions. A little bit for testing and not much to be talked about for other services, such as speech or language therapy. So we really have an occurrence of 96% under non-medication interventions and a total cost breakdown of 64% at the non-medication intervention bucket. Also to note is that the average cost per case came out to be about $5,838, with 13,000 children served, or youth, children and youth. The next slide shows an episode cost distribution across the behavioral health provider organization. So this is similar to the same thing you saw for the physicians. And as you can see, it's a little more widespread across the universe, with some outliers to the right.